Right, welcome everyone. Kia ora, good afternoon. I am Trina Cooper. I'm the General Manager for Partum. Today's pop-up chat is about perinatal bipolar with Dr. Sue Luty. This session is being recorded and will be made available on the Partum website. We ask that you remain muted, and if you wish to ask a question, please use the chat function that you see at the bottom of your screen, and these will be addressed at the end of the presentation. Dr. Sue Luty is a psychiatrist from Canterbury DHB and will today provide an overview of bipolar disorder in the perinatal period, with emphasis on recognising, understanding the signs and basic principles of management. Sue, over to you.
Thank you, and thank you for asking me to do this presentation. Look, I work in Christchurch at the Mothers and Babies service, so I work a lot with women with bipolar disorder and certainly mood disorders, and we have, as a service, developed a number of strategies for helping women plan for pregnancy and for managing during delivery, during the immediate postpartum, and are pretty experienced. So what I want to do today is, for those of you who aren't familiar with bipolar disorder or kind of know a little bit about it, just to give you a very brief overview of the kind of symptoms that we do see and what to, I guess, look out for. I'm going to focus also specifically on postpartum psychosis, because this is invariably either a recurrent episode or a new onset of bipolar disorder. And it is really important that you are aware of its existence, the risks around it, and what to do. Part of what we need to really try to do is identify who is going to be at risk of either a new onset, perhaps those who you might be a little bit concerned about because of their history, or who might be at risk of a relapse, because not everybody with bipolar disorder is going to relapse in the postpartum period. In fact, many of our women stay very well. I'd like to think it's because we have good strategies for managing and a good oversight and good family whānau involvement and education. But it is important to know who should be referred to mental health services. And I'll obviously be incorporating our service criteria when I talk about this, but these would be common to any mental health service across New Zealand. There are, I guess, some complexities around managing bipolar disorder, issues like medication, acceptance of diagnosis, managing the very tricky sleep cycle during pregnancy and certainly postpartum, and knowing and having at your fingertips the kind of options we have to help people stay well. And certainly what we see is women presenting during the childbearing years, which where we're concerned in Christchurch is from any age of from 13 upwards, although we only see outpatients from 18. The best scenario is when somebody is fully informed, wants help, comes along to discuss management, particularly pre-pregnancy, because they're planning very sensibly. When they're already pregnant is the typical scenario. We will see people, and it's useful to think about when might be the best time to start planning, and I think no time's too soon. Often women will present postpartum because they're having perhaps some grumbling symptoms and signs and need some input. Very occasionally I should say, some women are presenting because they are so unwell that we've ended up thinking about the Mental Health Act, and this would be in the case more often than not with postpartum psychosis because of the degree of unwellness that these women present with. And this, I just think, is too late. We want to capture and understand who might be at risk. So this talk today will be able to, I guess, address some of these issues. Certainly what I see are a number of different questions or guess, misinformation or part information. Most definitely is misinformation and is very unhelpful is somebody saying, I've been told I shouldn't get pregnant because I have a mental illness. That is just not what we want to hear women saying. For those of you who are interested, there is a really lovely book, now quite a few years old, written by Kay Jameson, who had bipolar disorder. She was a researcher in mental health in the US, and she was told by her treating psychiatrist that she shouldn't have a baby because she had bipolar, which it still does happen today sometimes, but a very moving narrative of her experience. Women who can't quite capture what they've experienced before might say, I've had something that's a bit postnatal. That sort of statement, we want to have a bit more clarity around what kind of symptoms the person experienced. Certainly medication's always an issue. Can I get pregnant on this medication? Oh my goodness, I'm pregnant already. What on earth do I do? Big message is don't stop it. There's plenty of time to discuss what to do with medication. I've just found out I'm pregnant. Will this get into my breast milk? And thinking ahead, that should be even in our planning. Is this medication safe for breastfeeding? Many women don't want to take medication, so we need to think, how would we advise that if we know there might be a risk of relapse if the medication is stopped? Sometimes the baby is presented, I guess, as a tool, as a means of communication. Unsettled infants, poor feeding. And this might be an indication that the mum is unwell or is conveying something about how she's managing with parenting. Certainly family members often do get concerned about either relapse or what about medication. And of course, there's always the genetic question about, is this something that I might pass on to my baby? What we do know, and this includes all psychiatric diagnoses, but in particular bipolar disorder, that the risk of suffering an episode or having a new onset illness is higher after childbirth than at any other stage of life. So we're dealing with a very sensitive time because women may well have a new episode and are adjusting to living with a baby. And how do you juggle the joy of the baby with perhaps the challenges of a new diagnosis? I'm going to show you a graph next which kind of illustrates this. It's sort of a well-known graph in our perinatal mental health services, but it's demonstrating the psychiatric admissions to hospital after childbirth, and it shows the admissions before and during pregnancy, so for a 2-year period, and then these go up hugely during the first couple of weeks postpartum, and then still stay high for up to 2 years. So the risk of having an episode is still increased. Of note, it's neither increased nor decreased during pregnancy. So pregnancy is neither protective but nor detrimental to mental health. Highest risk time, this is a really, really important take-home point, is the vulnerability in the immediate postpartum period. And this is why we have a very, very clear birth plan that we set up, and it's important to discuss that with whoever you're working with as to how they're going to look after themselves and be looked after in that first sort of few weeks. Now, why bother? Why be concerned about symptoms? More importantly is the impact of maternal mental illness on a number of different areas. We have the potential for women who have symptoms, and it may be just that they're too preoccupied or perhaps more unwell with their illness, to not attend their obstetric clinics, and this can have a flow-on effect. I guess less obstetric care and poor outcomes for the baby. And then we do have the very serious but very important risk of maternal mortality. Now we talk about direct and indirect, which broadly speaking is the direct effects of the mental health illness, which we would say suicide in the case of women we're working with, but indirectly because not looking after oneself, not taking your insulin or using your insulin, not attending to rest. So you have a more, an increased risk of diabetes complications if they're not managed correctly, or high blood pressure, or other obstetric complications. The biggest risk, I think, is the flow-on effect with the relationship with the baby. If a mother has symptoms, I think most of you who are dialing into this will be very aware of attachment and the mother-baby interaction. If we have a preoccupied, very unwell mum, then we have a mum who's not optimally interacting, touching, talking with, making eye contact with her baby, and maybe quite frightening to the baby, or maybe frightened of the baby. With that then comes attachment, which is not a secure attachment, and we do know with the more insecure attachments or disorganized attachments that the later outcome for that infant is impaired. Now, I thought I should just talk a little bit about what bipolar disorder is for those of you who aren't familiar with the symptoms. We do know it falls in the group of major mental illnesses. So by that I mean that there is a risk of a hospital inpatient admission when symptoms are severe enough. Other mental illnesses you don't see as many, e.g. anxiety, in the hospital setting. Now, bipolar disorder is not just postpartum depression or PND, which I don't like as an acronym really. So it's not just depression. And I'll talk about the symptoms in a second, about what the actual patients experience. It isn't a very common illness. If we pitch it against depression or anxiety, we're looking there of 20%, 30% even of women have anxiety in the general population, perhaps even more than that. So bipolar disorder is present in only about 2 to 4% of the population. If you use very, very narrow, strict criteria or very severe criteria, it's the lower number. But if you are a little bit broader with your numbers, it's the higher number. Now, I've said depends on definition. You may have heard of people who use the terms bipolar 1 or bipolar 2. Bipolar 1 is the more severe disorder, severe and sudden. But it is important, if you think about the risk of relapse, which is very high, particularly if off medication, the risk of relapse is up to 75% after delivery. And if we go back to that first 2 weeks, this is the time of optimum connection that the mum wants to make with her infant. And so, of course, if the relapse is high, and this is a time of connection and attachment relationship formation, the potential for the detrimental effects is there. And so if we can recognise who might be at risk of relapse, we can prevent those detrimental effects. And certainly, again, planning for pregnancy, planning and preparing for delivery, having optimum supports postpartum is absolutely crucial. So if we just talk about the symptoms of bipolar, simplistically it's bipolar, it's two opposite poles of mood. So periods of elevation, which we describe elevation using the terms hypomania and mania. What this means is different degrees of elevation. So higher than normal mood, not just feeling happy or a little bit high, means prolonged, at least for 5 days, of symptoms of elevated mood. The elevated mood will also have periods of overactivity, impulsivity. Perhaps this involves overspending, doing things you wouldn't normally do, driving fast. Certainly impaired sleep is a huge aspect of elevated mood. Now, impaired sleep when mood is elevated is usually referred to as decreased need for sleep. So it's less sleep, but I don't need that sleep. So waking after only a few hours, but not feeling particularly tired. So the periods of elevation can also have irritability woven in. So the degree of severity of the elevation, however, means we would describe mania as being extremely severe to the point that this impairs functioning and there starts to be risk involved. The severity also in mania may include psychotic features, which would be disturbances of reality, hearing voices, delusions of grandeur, this kind of thing. So it's quite a severe episode is mania. Hypomania isn't as severe. People can miss hypomania. Certainly, I recall a patient I treated many years ago who had a number of depressive episodes and then down the track developed a manic psychotic episode. And I had missed her hypomanic episodes. And when we went back over the history, what she could do at school was study overnight without needing sleep and was quite happy during her exams. And they were kind of signs that probably she had hypomanic episodes briefly during her teenage years. So you can sometimes miss this. And often people can be more productive with hypomania, so not necessarily impaired. So again, it can be missed.
So just a quick question. Somebody's asked, do you know the chance of relapse if on meds postnatally?
I have graphs for that. Okay. I think I can talk to that when I show those graphs. Yeah. Certainly periods of depression in the bipolar spectrum are much more common. If I was to show you a pie chart of the number of symptoms, the mania will be a little tiny pie bit, but the depression will be a much bigger part of the graph. So bipolar is often lots of depression, and lots of depression for years before the first manic or hypomanic episode. When we look at studies, it can be up to 10 years of depressive episodes, then all of a sudden a mania or hypomania, and more likely than not, this will be in the first postpartum period. The atypical features that I note there are particular types of depressive symptoms, which are very common in women, but can pre-herald the onset of a clear diagnosis of bipolar. So atypical features of depression are what we call non-melancholic. So somebody typically, when you see them depressed, are very withdrawn, they don't brighten up, their facial expression is very restricted, they can't get to sleep, they are absolutely exhausted, they can't think straight, they often don't eat and lose weight. Now, atypical features are the capacity to brighten. So you can see somebody who's smiling and talking about their mood, and they can feel a little bit better for periods of time. They can also oversleep. So instead of not sleeping, they will sleep and sleep during the day. And that's often a symptom that you see the most. And certainly overeating, eating more than normal and putting weight on. And another feature we call leaden paralysis is a sense of women just, you feel really heavy in your chair. You ask somebody, when you're sitting in a chair, do you just feel like your arms and legs are like leaden weights? So if you have those features in early depressive episodes, you are starting to raise a little red flag. Could this end up being bipolar? I don't want to alarm everybody that you're seeing who's got depression and say you've got to run around and suggest that it might be bipolar, but it's useful to have in your mind. If you see that, note it and have it as an option. The medication treatments for bipolar, the mainstay really is mood stabilizers. These treat the depression and the mania. They stabilize the mood. They don't keep people blunted or dulled. The side effects might, but they stop this cycling of mood, going from periods of depression to periods of mania. And staying on them prevents relapse. The typical mood stabilizers that have been used in the past have been lithium and sodium valproate. But there are issues with these during pregnancy and breastfeeding and postpartum. Sodium valproate is now contraindicated, and I really need to stress that it's contraindicated during pregnancy and breastfeeding. We used to prescribe it. I've been working for 18 years now in perinatal psychiatry, and we used to prescribe this quite a bit. But its capacity to form brain and heart, so cardiac defects, i.e. its teratogenicity, is up to 12%, if not higher. The base rate in the normal population is about 2 to 3%. So you can see it's probably about 4 times higher than the general population. So if women are on this now, they need to be warned, they need to sign consent and be reviewed and be on 2 forms of contraception. We just don't endorse it at all. Lithium, which is an excellent mood stabilizer and works very, very well for mania, is slightly problematic during breastfeeding. It's fine during pregnancy. It used to be thought that it was teratogenic, but that's been reanalyzed. It's been refuted, that data. But during breastfeeding, it is one of the medications that annoyingly goes through in high concentration in the breast milk. So the baby gets exposed to high concentrations of lithium. Now, lithium, albeit a salt, is toxic if it accumulates. It's certainly toxic to humans if levels go too high, which is why we need to very carefully monitor the blood levels. But for babies, it can cause cretinism, hypothyroidism, and damaged kidneys. And so if somebody insists on breastfeeding, we don't fully endorse it, but we have supported women. And with neonatal pediatric support, we do have a little bit of a protocol. We have to very, very carefully watch the baby and do blood levels and go in for blood tests, which can be a little bit stressful for the mum. So we tend not to use those. So just to labour a point, it is really important to note those 2 as being problematic. We use a lot of antipsychotics as mood stabilisers, however, and these are safe during pregnancy and breastfeeding. The issue, I guess, for bipolar is being very mindful of supporting the mum and having the correct treatment and the correct support, but also thinking about what the risks might be for the baby. We have to look at what supports are in place to be non-judgmental and non-stigmatizing and make sure that they're all in place. Unfortunately, we sometimes do have to make decisions about notification to Orangutan but this isn't without very, very careful consideration and good discussion with the mums. But what we're thinking here is there's a baby. There's more than just the mum here, and if a mum is very, very unstable, very unwell and very psychotic, particularly psychotic with delusions, there is significant risk for that infant. These, unfortunately, are the very rare but tragic circumstances when mums will suicide and also, unfortunately, kill their infants. And if you care to read such material, there is a very poignant but well-written case scenario which led to the guidelines for monitoring women and liaising women with bipolar from the UK, which is a story of Daksha Enshon. And I can give you a connection to that. It's the report around her history, really. So coming back to treatment, though, psychotherapy is an incredibly important consideration for women with bipolar. Psychotherapy really does help women who are adjusting to living with bipolar disorder and perhaps not going down the trajectory of life that they thought they might have. It helps them adjust to self-stigma and to learning to live with the illness and manage themselves. And a really important part of managing is thinking about the sleep-wake cycle and circadian rhythms, which of course are notoriously destabilised during the perinatal period. But there's some very good top tips and tools for managing bipolar on a website called ipsrt.org. And this uses a self-monitoring tool to keep people stable with their sleep-wake cycle, because this is so important. So the psychotherapies that work in addition to the medication are part of what we would recommend during our work with women. Certainly when working and talking to women, it's very important, as I said about Kay Jamieson, that women with psychiatric disorders or bipolar disorder should not parent. I mean, what was it like to hear that? We do see some doctors, I'm very sorry to say, making statements such as the medication will harm the baby without any real knowledge or understanding. The two key ones really would be sodium valproate, possibly lithium, but other medications, while there are relative risks such as slightly lower birth weight, slight prematurity, are not harmful to the infant. There may be a mild withdrawal syndrome, but it's not, it's self-limiting and not severe. And the why are you taking that medication statement is one that we hear mums reporting. So I think one important point will be just watch what you say and how you say it, because it can be so, it can so feed into the stigma that some women feel about having a psychiatric illness, and we don't want to kind of add to that burden. The other ear that you need to have, though, is understanding when supports might have these opinions or be making statements such as this, because of course the home situation then won't be a particularly supportive one. Now I want to mention postpartum psychosis, because this is the very sudden onset, very severe psychotic disorder, which is usually bipolar disorder. In the general population, 1 in 500 women become psychotic postpartum. 1 in 500 births, I should say. If you have bipolar 1, this is increased 100-fold. So it's very common if you have bipolar 1. And what we usually tell our mums, we would call this bipolar 1 disorder, unless there's a really obvious trigger such as drugs. So we do get some drug-induced psychoses. Postpartum psychosis is a severe, sudden onset of psychosis, which can be extremely severe. Often the delusions are related to the new child, so that this is some devil. It's not theirs, it's not real, it belongs to somebody else, it's been substituted. And the symptoms can be a kind of a mixture of symptoms. We can have a mum's can seem elated in 1 minute and then extremely depressed. So the clinical picture can change very, very rapidly. And in that first week, sudden onset, it's a psychiatric emergency and requires attention quickly because of the risk to the child. Some of these women can seem almost physically unwell, so quite confused, bewildered, perplexed, and there's the potential for this diagnosis to be missed if it's kind of a bit low grade, and clinicians to think this might be the beginnings of a breast infection, something like that. So again, it's really important to take a careful history and observe, and if in doubt, I think refer for an assessment. So triggering the bipolar in the immediate postpartum, clearly a family history of mental illness, which is specifically bipolar, would be the most, I guess, common. And so the first thing to, I'm just going to flick forward one slide, because if we have a first-degree relative with a postpartum episode, and by that I usually mean the mother or the grandma of the baby to be born, a postpartum episode that's particularly required admission, or a first-degree relative who's got bipolar, that is grounds for seriously considering whether this woman might be at risk of developing bipolar. I've got a graph showing the risk in my next slide. I just want to go back a slide. So what we do know that there are, you are more likely to have a postpartum psychosis after your first infant, but you can go a couple of babies and then suddenly have an episode. So it doesn't mean that just because you haven't had an episode, you're not at risk. We're not entirely sure why. We do know that if there are complications during pregnancy, such as a frightening traumatic delivery, not just having a cesarean, but something that's frightening to the mum that activates all those stress systems. We do think that the hormonal factors at birth play a role. What we certainly know is that if, and these are studies that go back when women used to be withdrawn from their mood stabilizer. In the past it was lithium, or it's still one of the antipsychotics. If women were withdrawn from their mood stabilizer and not on medication, their risk significantly increased. I think somebody asked this question. It's probably a 40% increased risk if you stop your mood stabilizer. You need to stay on them. That's our usual advice. And if there is going to be a withdrawal of a mood stabilizer, because some mums really choose not to continue, and certainly some mums stay on lithium, want to breastfeed, so withdraw, which isn't ideal because you don't know how they're going to manage without the lithium postpartum. I'd rather do this before pregnancy. But if you are going to withdraw, it's going to be at least 2 weeks of a taper. And that would be my absolute bare minimum. And I'm very cautious. I would do it over months. And of course, the relationship between mood symptoms and sleep is so intricately entwined that sleep is a symptom of a mood episode, but sleep deprivation can cause. And sleep deprivation alone, if we look back in the histories of many of our women who've had an episode postpartum, it's because they haven't been able to attend to the sleep. And having somebody alongside who can help you manage what you're going to do postpartum to keep that sleep up is really important. And I've had some mums say, my sleep is so important, and I know that that's a trigger for me. I'm not going to breastfeed overnight. I'm going to either save my breast milk, or we're going to use formula, and my partner or somebody else who's helping support us is going to feed baby for me so that I can get the sleep I need. And that's a really important consideration when managing some of these women. So I've already mentioned the predictable risks are the past history, the purple psychosis. If you've already had, people used to call it puerperal psychosis. So just being aware that that can be, that's the same as postpartum psychosis. And then these first degree relatives, female relatives, usually the mother, having an episode postpartum requiring admission or having a diagnosis give you a risk. Now this graph shows the general rates and how they hugely increase. So here's the base rates, general population, which is per 1,000 deliveries. So it's negligible really in the general population, but it increases to about 250 per 1,000 for women who have bipolar already diagnosed. If you've got bipolar and a family history, your risks increase as much as if you've already had an episode of postpartum psychosis. So it is important to keep that note in mind, that if you tease out that statement from the mum that their mum had a postpartum episode, it's important. I put this a slightly different way here. This is if you start at the bottom, if you just have the patient who's pregnant, if her mother had postpartum psychosis, there is still an increased risk of an episode, which isn't as high as if you've had a previous episode of postpartum psychosis, but as you see, it goes up. An equal risk if you've got in the mother or episodes of bipolar or postpartum psychosis, going up to as high as 70%. Some of us would argue 75% if you've got all those three risk factors. It's really important to take a good history. So I think I've already said this really, that the accurate diagnosis often for bipolar, if you think about being well or having had depression, and then all of a sudden you've got the postpartum psychosis, you're suddenly diagnosed with bipolar disorder. And this is, here I am, I've got a baby, and now I've got bipolar, which is a really difficult one to manage for some women. So the referring women early to regulate the disorder is really important. Is it psychosis or we're not sure? Really rational reason to say, can you assess this woman? We're not sure if it's bipolar or if you're really clearly diagnosed with bipolar. And then if they've had depression, and remembering possible atypical features being a risk of bipolar, and especially if they've got a family history of bipolar and a postpartum psychosis, these women need to be referred for a psychiatric evaluation or to a maternal mental health service if there's a specialised one in your area. There are some recommendations that the PMMRC suggests, such as, have you ever had treatment for what we would call a severe mental illness? What about treatment from a psychiatrist? What about family history? And then at the booking visit, antenatally, to check whether they've got any active symptoms of depression or low mood, and to be reminded that their illness can deteriorate very rapidly postpartum. And unfortunately, we do have high rates of suicide in New Zealand. And the PMMRC recommended an inpatient unit in the North Island, and this was opened within the last few years, which is wonderful. But we are still the only South Island unit with only 5.2 beds for the whole South Island, which is slightly challenging. I just want to briefly mention one of the things that's really helpful is also referring early. So not just waiting till the last minute. We try to see by 28 weeks gestation or earlier because we like to get on board. Education around bipolar. We will prioritise people who are referred very late in the pregnancy and see them as urgently as possible because we want to create a plan for delivery. And unfortunately, those of you who are in Christchurch, this is why other referrals might get pushed down the waiting list because we really want to see these women before they deliver. And we're always talking about medications and therapy. And so we create with these women a mental health support plan. I did one only this morning, actually, and it's a really helpful process. We meet to maximise supports, make sure that best treatment happens when women go into the women's hospital, that their medication is really clearly documented, and we're aiming to improve safety. And of course, liaison and communication, that it's not a sort of a mystery about what needs to happen for a woman and her whānau. So we meet at 32 weeks, and I did one only a week ago on Monday, and goodness me, that was just in time because she delivered early on Wednesday and we got the plan all ready and sorted, so we were very pleased we did this. She had that she'd been living overseas, so we planned it as soon as we could, a bit late. So we meet with the mother, the partner, whānau if they want to go, the LMC, psychiatrists, case managers, and anybody else who wants to come along, really, within reason. But we do involve communication with all these individuals. So we talk about what's the diagnosis, when's the due date, what sort of medications is this woman taking, and what do we need to think about during delivery, what might be the risks during delivery, and what are we going to do to support this woman. We think about staying on the ward for longer, getting enough sleep, so 3 to 5 days on the ward, and how are we going to check up on her postpartum? Will we need to admit her? How are we going to make sure that she receives excellent care that's non-judgmental? So none of these statements that we used to get when they brought in medication, which would say, you're on this, are you? We're writing, she is taking this, please prescribe it. You've got a mental health diagnosis. Oh, you need to be checked before you go home. No, we've already stated we are going to review, or we will review at home. We don't need to see the women before they're discharged. So it's really important then to know who's high risk and to refer early so we can get this plan in place, because this is incredibly important. And ongoing management then is around sleep. It's sleep, sleep and more sleep, and looking at the medications, thinking about what would be best for this mum to keep her well. Therapy, keeping all those supports in place, and at the same time keeping that baby in mind, attending to the attachment relationship. Planning ahead, I've already mentioned that we do pre-pregnancy consultations, and I think that is incredibly valuable. High-risk individuals or women with bipolar, we can talk about, look, I'm on this medication and I don't really want to keep taking this, or what do I do about the dose, or will I need to change it? Look, I'm on valproate and I've been using very heavy contraception. I want to get pregnant. What do I do? How do I switch it? What about my lithium? Can I breastfeed? I want to really talk in detail about this. And then that means that they've had a conversation and they're informed enough. And then they can plan and come back pregnant if we advise that they come back, which we would do if they were bipolar. And we can have a written plan and how to manage and how to manage during pregnancy that we might also give to the mum. So look, I've whizzed through quite a lot and I've focused on some bits, skipped over a few bits. Not a lot of in-depth management. I'd say the key points would be know who's high risk. So know who is the high-risk individual. If you screen and keep them on treatment, we're talking about saving lives and the mother-infant relationship. There will be a risk-benefit analysis when we're thinking about treating, but especially with the medications where somebody might be well and might need to stop medication. And we're thinking about managing and preventing and planning ahead. So planning ahead for the delivery and the early postpartum period so that we can keep women well. And knowing who might be at risk of relapse if they stop medication, knowing how to help people adjust and think about how we, I guess, adjust to living with, now this is bipolar as well as a baby. And of course, it will be a challenge, and this is beyond today's talk, that who might end up being somebody who has an attachment issue. And hopefully, I mean, that's certainly, we have a specialised psychotherapy psychologist here who works with these women. But also we're on the end of the phone providing advice. So those of you who are in our region, you can phone us and we will always be more than happy to give you top tips or suggestions or what to do, or is this what about this history, is this psychosis? So please, more than happy to have a conversation if you want. Now I think that's my last slide, Trina. So I'm happy to take questions. I've seen a few coming up, and I've got. How would you like me to do this?
Yeah, I mean, we'll give people the opportunity to type more questions if they want to. I mean, you touched on the chance of relapse if on meds postnatally, so that's been covered.
Yeah.
And there was just another question just about that website for the circadian rhythm, which is the ipsrt.org website, isn't it?
Yeah. And what you have to do is pretend you're a clinician and log in, and then you're using it for training. But and then you can download. There's actually a very good sleep. What's the word? A sheet, top tips for sleep management, and there's some lovely presentations about the therapy, which is IPSRT, interpersonal social rhythm therapy. Ellen Frank is a kind of a world guru on psychotherapy for bipolar disorder, and Holly Schwartz, the other person. So yeah, it's some useful information. The other, I mean, I guess this is going more into sleep management, but the other good sleep management, if we're thinking non-medication strategies here. I'm often referring women to not just the meditation, relaxation, sleep hygiene, but there's a very good phone app called CBT, I think it's -I, which is CBT for insomnia, and it's got some, CBT for insomnia, and it's a turquoise icon with a little moon on it, and that's got some tools which are guided imagery and relaxation. It's American, but it's tolerable, the voice. That's quite good.
Excellent. Yeah, just any helpful little apps and websites and snippets and things like that are always just so useful for people to look at. Like you say, it's an alternative to medication, or it's something that can be used alongside medication as well.
Yeah. Now I can see. I couldn't see the chat. Now I can see the chat. Oh yeah, I'll type in the website.
Yep, we've got the ipsrt.org.
Make sure you've got that.
Great.
CBTI is the phone app. There are also, I need to go back up again. No, there's, you've got the meds. The information about bipolar, there's, what's it called? There's Balance, and there is, what's the other one? It's gone. It's off the top of my head. I can't remember it now. But there's some good websites that just have more information about bipolar.
Great. Well, if you think of any of those, then you're welcome to forward them to us, and then we can just share them with everyone there as well.
The book, I think it's in my talk, but An Unquiet is that's the book, which is it's a sort of a sobering, quite sad, but really heartfelt story from an academic researcher about her experience of living with bipolar.
Yep. So that book is called An Unquiet Mind by Kay Jamison. Great. Well, that's excellent, Sue. I think you've covered a huge amount in our little short time that we allow for the pop-up chats. Really, really appreciate your time today. As Sue mentioned, she's happy to be contacted if anybody needs any further information or guidance around the topic, or else contact your local maternal mental health group at the DHB that you're associated with as well. They'll have a lot of similar information available relative to the region that you're in as well. So we'll let everybody go now, and Sue, I'll just keep you there. Thank you.
Thank you, Emma.
Great. Thanks, Sue.